So good morning, everybody. Thank you very much to the GIS and the Sky for this invitation. I'm going to talk about AI and the patient risk stratification in acute coronary syndrome. I don't have any conflict of interest. As we discussed right now, artificial intelligence is going to do a revolution in medicine and in cardiology. Right now, the application of artificial intelligence are in every part of our clinical workflow, from treatment to diagnosis to clinical findings and to imaging. But if we want to group together and to schematize the application, both in clinical practice and in research field, we can difference from an application in early diagnosis, so the diagnosis of asymptomatic patients of new undetected disease, to a disease classification, and further to risk prediction of patients with already a problem, already a disease, and to understand which is the risk of these patients after the first event. To the holy grail of have a tailored clinical management and to have a tailored clinical follow-up to our patients to improve prognosis and further also reduce costs. So we're going to talk and focus on risk prediction and risk score. But what is a risk score? Every time we heard let's feed the artificial intelligence with data and we see. How does it work, a risk score with artificial intelligence? So we gather data from patients, we gather both baseline clinical characteristics, clinical findings, ACG and imaging data. We put together in an Excel database and we built what we call a derivation cohort, so a population in which with artificial intelligence we train a model. The training could be supervised, so we say to our system, okay, these are the baseline characteristics, these are the outcomes, you have to recognize this, or it could be unsupervised, so we leave the model working on its own. And then when we have a model, and this is very important, we need to validate it in a new population that could be a part of the first database or could be another population, because without internal or external validation, we don't know if our risk score is working well. So in acute coronary syndrome, we have two big categories of risk score. So we can estimate the risk of patients with a current ACS, I mean patients admitted to the emergency hospital with acute coronary syndrome, and to estimate their risk of death, of complication during the hospitalization, and understand which is if you have an early treatment benefit in treating these patients. Or we can estimate the risk of a second event after acute coronary syndrome. We discharge the patients and then we estimate his risk of adverse event at follow-up to try to tailor a follow-up on these patients. So, focusing on the first part, we all know the GRACE 2.0 score, which is endorsed by the guidelines, and now we have the new GRACE 3.0 risk score that has been published last year, and is based on clinical presentation, clinical features, lab values, and the ACG alteration. We have a very, very friendly user app in which we can easily put these characteristics, and we have the risk of the patients. And we can choose if doing an early invasive management in these end-STEMI patients or to do a delayed invasive. So here you have the online tool. And as we can see, the GRACE 3.0 is working really well. It's an evolution with artificial intelligence of the GRACE 2.0 score. And for the first time, it accounts for sex differences. The GRACE 2.0 had a really huge problem with female patients. The GRACE 3.0 right now is accounting for sex difference, and that has an excellent discrimination and a very good calibration. Here you can see the feature values importance of the model. So with just these variables, which are creatinine, age, heart rate, systolic blood pressure, ST segment deviation, and key lip class, you can estimate the short-term risk of mortality of your patients. And as I said, it works really, really good, both in female and male patients, with an internal validation area under the curve almost 0.85, an external validation of 0.87, both in female and male patients. And the GRACE 2.0 was really, really low. It was around 65 to 70. And last month, because as we discussed before, we really need a validation of this risk score on a very broad population. And last month, we published probably the largest validation of a risk score in cardiology, with 186,000 patients with NSTEMI across all Europe from 10 European countries. And we validated the grade 3.0 on this cohort. As you can see on the right, the performance was very, very good in all the countries, and the variables were the same. The importance of the variable was the same of the original grades 3.0. And really importantly, it was possible to divide the patients into two groups, in patients with no to moderate benefit to early intervention, and to high benefit group of patients to early intervention. And you can see from the Kaplan-Meier the importance of doing an early treatment in these high risk and STEMI patients. We reduce the mortality of 40% in these patients. What is the future of risk assessment in this patient with ACS? In my opinion, is deep learning with baseline electrocardiogram of patients that are arriving in the ambulance. We have now the technology. These are two studies in which simply scanning with your phone the ECG, they estimated the risk of coronary occlusion, and they estimated the risk of adverse events in patients with chest pain and ACG. So now we have the technology, and we really need to use the baseline ECG to estimate the risk of mortality and of shock development. So moving to the second part, so to estimate the risk of a second adverse events after ACS, because now our patient had an ACS, okay, but we need to tailor the follow-up, to tailor the medical therapy to each patient. So this one was the first machine learning and artificial intelligence risk score published in cardiology and in acute coronary syndrome that we published in 2021. And let me tell you the story behind this score, because many times in medicine, in cardiology, many discoveries are made for chance. So, as you know, Italy in 2020 was really hit badly from COVID. So all our hospitals were shut down, were converted into COVID hospital. Our hospital was almost the only one in which we still treated like ACS patients. And we were really alone in the cath lab, because patients, they didn't present with STEMI, they stay at home, they didn't present for fear to catch COVID. So we were literally doing nothing in the cath lab, and our chief decided we have the biggest outpatient clinic for ACS patients. We cannot see these patients in our hospital. We need to find patients with high risk, because at least we have to see these patients after an MI. We cannot leave all the patients 1 year after follow-up. And so we decided, why we don't try with artificial intelligence to estimate which patients are high risk of recurrence of MI after an ACS? This is what we did, and we published this risk on Lancet in 2021 on almost 20,000 patients with ACS in Europe. We externally validated on more than 3,000 patients, both STEMI and NSTEMI. And these are the variables we used in this score, in which we estimated the risk of all-cause death in the first year after MI, the risk of recurrence of acute myocardial infarction in the first year, and the risk of major bleeding. And you can see these are really easy variables that you can find in all the patients, so ventricular ejection fraction, age, hemoglobin, statin, renal function. And the performance on the score was really high, with an area under the curve of more than 0.90 for estimating all-cause death in patients at 1 year after MI, 0.81 in myocardial infarction, and 86 in major bleeding. But also here, what's the future in risk prediction after ACS? I mean, I think that combining clinical and imaging data, so directly not only the clinical data that we can get for the patient, but now we have the possibility to have the images to go inside the artery of the patients to estimate his risk of recurrence of events. So now we are working on this new model that we recently published the protocol that is called the Predict AI model. We enrolled more than 500 patients with acute coronary syndrome with a viable OCT. And we wanted to estimate the risk of MACE, including all-cause death, MI, and target vesicle vascularization at the follow-up, based on both clinical and OCT images. So in the phase 1, we extracted the features of OCT with the OCT Plus software, and then we trained the model to develop a risk score of adverse events for each patient. Now we are working on an external validation, but I will show you right now the preliminary results are quite good. These are the features importance of this model, and you can see that it's a mix of baseline baseline characteristics, of laboratory characteristics and OCT data. And here you can see that these variables are linked to an increased risk of events, so CRP, LDL, but also plaque burden, calcification, crystal of cholesterol, and MLA. And the project and the risk score works extremely well. We have an OC of 0.95, so is really good in predicting adverse events in these patients. And in conclusion, so machine learning risk score should be used to identify high-risk patients and to allow a precision medicine on our patients. Now, the latest guideline encourage to use the GRACE 2 and the GRACE 3.0 to estimate the benefit of early intervention in ACS patients. And I believe that deep learning image-based risk score will transform our practice. Now we will have in the future the possibility to use directly the images of OCT, of IVUS, of CCTA, and estimate directly the risk. But, and this it's a very big point of discussion, we need a robust, precise, large data set, because
we are run out of time.
Okay, because as you know, if we feed our model with garbage, we will have garbage, maybe with very
Could you
good
open the last slide?
Okay. No. Maybe we will have garbage. Maybe we will have a very good discrimination caliper, but we will have a score that it doesn't work outside our cohort. Thank you very much.
Thank you so much.